everyone to the May 2021 edition of the Greater Manchester Connected Health Ecosystem. For those of you who are new to the ecosystem, we are a community of researchers, professionals, innovators and entrepreneurs in connected and digital health technologies. The ecosystem is hosted by the Christabel Pankhurst Institute at the University of Manchester, but the community extends far beyond the boundaries of that institute and even the university. So we've got people typically from academia, industries, NHS and the public sector joining these meetings. So it really cuts across different sectors. And we are part of the ECH Alliance, which is an international network of similar ecosystems across the globe. And I think Andy Bleeden, who is the chair of the ECH Alliance, is going to join us today, but I don't see him yet on the call, so he might be joining us a little bit later. Let me quickly share screen to show you our agenda for today. So the main focus of today's meeting is on the COSMIC-19 and EMBRaCE-GM projects. And after that, we're going to have two short presentations about the two foundries that we have in Greater Manchester, the AI Foundry and the Cyber Foundry. And we have a short presentation about the ERDF RNI Accelerator project. But that is all later on. So without further ado, let me introduce our first speaker, who is Anthony Wilson. So Anthony is consultant in anesthesia and critical care at MFT, and also the group clinical research informatics lead for the Hive EPR program. So that's a transition to EPIC at MFT. Anthony also enjoys the dubious privilege of being supervised by myself for his PhD. But for today, what is most important, he is the lead for the COSMIC-19 study. So thanks for joining today, Anthony, and the floor is yours. I will give you a heads up when you've got 2 minutes left.
Thanks, Niels. That's a great introduction, and yeah, well, thank you to everybody here for the opportunity to come and speak to you about the COSMIC-19 and the EMBRaCE-GM projects. That I'm really one member of quite a big team. So I'm going to share my screen now, if that's all right, and we can get started. Thank you. Apologies for the delay. So yes, as John's explained, the EMBRaCE is an overarching project where we're looking really to utilize wearable devices in cancer treatment pathways. But before we get on to that, we're going to talk first about COSMIC-19. So Zoe, if we could move forward. And really, as I said at the start of all this, this project is a collaboration between a large group of people, but the three people on the call that are going to be talking to you today are myself, Zoe, and John, who you heard from briefly before. And we're going to start by talking about the COSMIC-19 trial, which is almost a precursor really to the EMBRaCE work that we're proposing to do. So Zoe, if we could move forward again. The next slide just really summarizes the agenda of the things we're going to talk about, and that's already been shared. So we'll move on one more as well if we can. So yeah, so COSMIC-19 is a trial that we originally envisaged doing back in 2018, 2019, looking at using CE-marked wearable monitors in hospital for patients that were undergoing CAR T-cell therapy. And we had a sort of proposal worked up with the IMACH group at the Christies and MFT, who look at advanced cell therapies in cancer. And had linked up with a company called Isansis, who make a sort of CE-marked medical wearable for use in hospital. And we're planning to look at patients that were having CAR T-cell therapy and see if we could monitor them in hospital using this continuous vital signs platform. And then, of course, COVID came on, and we were fortunate that Innovate UK, who fund the IMACH programme, were very kind enough to let us pivot and use the plan that we had to monitor the vital signs of patients on wards with CAR T in COVID-19, and to see if we could use this wearable vital signs platform to the benefit of patients who had COVID-19. So the nice thing about that was that it meant that we were able to pivot very, very quickly because we'd already got part of a trial set up. And I'm the principal investigator for COSMIC-19 at MFT, and the chief investigator for the whole project is Professor Fiona Thistlethwaite, who works at the Christie. So Zoe, if we can move on one more slide. And really, I guess you could summarize COSMIC-19 by saying that we sort of recognize that there's a problem with traditional vital signs and what we do on hospital wards at the moment. And here is me trying to sketch out kind of what happens to a typical patient who is being monitored intermittently by a nurse in a hospital. So they have their vital signs recorded at particular points, and at some point during the day or the night or whenever, the patients may deteriorate. And the challenge, of course, is that with intermittent vital signs, you may miss the exact moment when that deterioration occurred. And so there's what I call the gap, really, the gap between when the patient deteriorates and when the vitals are actually recorded. And so just by monitoring signs continuously, could we do better? Could we pick up these deteriorations more rapidly and potentially prevent harm to patients? And really, if we click on again, Zoe, this sort of highlights the fact that there are, quite a lot of problems with traditional vital signs. I mean, the first is that most vital signs, when they're recorded, go into an early warning score algorithm, and we make a sort of a score of the severity of illness that this patient has, and then we use that to drive rapid response teams to come and see the patient. But these are all just, if we go back one slide, Zoe, these are all just literally point estimates. We don't take into account any of the data that's gone before, in terms of a disease trajectory. It's just a single point estimate. The actual taking of vital signs is estimated to take between 2 to 5 minutes per patient, per nurse. And that's not much time for the individual patient, but adds up to quite a lot of hospital time by the time you factor it all in. And then there's sort of questions about whether or not, the act of measuring those vital signs, person to person is really the gold standard. We know that our nurses will sit patients up when they measure their oxygen saturations, so they get the best reading to write down in the score. And we know that patients will be on the best behavior when they're having their vital signs measured. And so consequently, you tend to get sort of, things like white coat hypertension and better oxygen saturations with a traditional vital sign than you might pick up with something that's measured more continuously without that observer effect. And of course, as I've said there's the mind the gap principle, the fact that patients can deteriorate before vitals are actually recorded on the next instance. So COSMIC, I guess, is one study to try and look at some of these things, so we can move forward. And yeah, if you can click on for us, that's great. Yeah. So this is really what the COSMIC project was all about. It stands for Continuous Signs Monitoring COVID-19. We had a package of wearable sensors that are Bluetooth linked to a Samsung Galaxy tablet that sits at the end of the patient's bed, that then Wi-Fi links to the hospital network. And you can see that there's a single lead ECG sensor that sits across the patient's chest with an accelerometer and a measure of respiratory rates, a wrist-mounted pulse oximeter, an auxiliary temperature probe, and an automated Bluetooth blood pressure cuff. And what we wanted to know was, really, can we monitor accurately with these devices? And with the data that we collect, is it possible to predict patients that are going to deteriorate, patients that are going to recover? And what sort of practical learning can we do about using these devices in adults in a hospital ward setting, particularly in a sort of COVID environment? So the idea to enrolment took about 4 months because of all that preamble work we'd done with the CAR-T patients. As it stands at the moment, we've recruited about 70% of our maximum target, which was sort of 60 to 70 patients. We've managed to integrate the COSMIC-19, the Isantis monitors with the hospital IT system, which was nose, mean, feet. And we've managed also to automate some data capture, so capturing some of the traditional EPR data from our healthcare records at MFT so that we can pull it straight into our electronic data capture tool for the research. So really the last bit of this is to talk about what we've learned so far, because I'm not in a position to be able to give you our full results because we haven't got those yet. But what have we learned about this whole process of using devices like this, wearable monitors and this technology in a hospital ward environment? So if you can move on to the next slide, Zoe. Actually, before we do, this is just an example of what we're able to do with this equipment. So this is just any old hospital computer that I can be using to look at any patient that's monitored with these devices remotely in the hospital. So as an ICU consultant, I can be sat in my office and I can pull up test patient 1, 2, 3, 4 in this case, which was me, and see some of the wearable data that's recorded. You can see those S boxes on the little circles on there. If you were to click on one of those, and Zoe, if you can do that, you can mandate the system to actually just press, you can mandate the system to bring up an ECG waveform It includes an accelerometer, so it allows you to do some remote review of the patient without me needing to leave my desk, which as an ICU consultant is something that I'm really keen on. So yeah, so that's a little bit more about the technology. What have we learned so far? So yeah, if we can move on to the next slide. Well, I think the first thing to say is, and this sounds like a sort of pithy comment, but tech trials are technical. And what I mean by this is you can see in this photo from some of our sort of news publicity that we've had is that we had a lot of research nurses that were working and supporting us on this project. But as a group of individuals that they're used to dealing with trials that involve, you know, medical interventions, blood tests, history, examination, these kind of things. And for many of them, it was the first time they'd ever had to use a piece of software like this. And they were needing to learn ad hoc how to Bluetooth link a Samsung Galaxy tablet to a blood pressure cuff and deal with the fact that it automatically puts it into airplane mode. And the fact that some devices desync, that you know, all those technical issues, and sometimes having to reconfigure the Wi-Fi on the server on the sort of Samsung Galaxy tablets. This kind of stuff led to loads of barriers and loads of sort of false starts as we were getting going. And I would say that there's a real need to invest some time in getting that right with the research team if you want to use this in a hospital ward. And then you can imagine that if you want to do that with an entire group of nurses, an entire group of wards for more of an interventional trial, there is a big learning need to make sure that this works well. The second is just the challenges of the ward-based environment. The Isantis platform is sort of small profile. It's not much bigger than a Galaxy tablet, but it needs to be charged. And even things like finding a space next to the patient's bedside where we could put this device or where we could charge it, a plug that was free and that wasn't being used by infusion pumps or other monitors, it is really important. And you need to factor that into how you do this. I mean, something that hangs off the end of the patient's bed is probably one of the best things you could come up with, but even that still needs that plug. We had some cases where I go into the room and see that the Isantis monitor was plugged into the plug on the wall that was being used by the cleaner for vacuuming, because that was the only place that the nurses could find to use it.
Secondly, we've got 2 more minutes.
2 more minutes, yeah. Some of this monitoring works well and some of it doesn't. Blood pressure cuffs were notoriously unreliable and difficult, and things that patients really didn't like to wear. And we found that actually patients will tolerate a blood pressure being measured by a nurse, but when you ask them to have an automated cuff on their arm, after a few hours, with no one watching them, they get really sick and tired of it and they want to take it off. Another point about the kit was that patients loved immediate feedback. So we found that although we were asking patients and staff to be blinded to the monitoring, patients were taking off the little sort of strip of paper that we put over the SATS probe so that they could actually see their own SATS, because they liked to know if they were moving themselves in the bed or lying on their front, if that improved their care. So that immediate feedback was really, really helpful. And lastly, I would say that this hospital monitoring is probably not ideal for the home-based environment. And I think you need to think carefully about which monitoring works well in which environments. A lot of these sensors require a bit of maintenance on a day-to-day basis to make sure they stay stuck on and so on and so forth. Just one more slide, and this just talks really about some of the other learning. Integrating with hospital IT, as I think a lot of you will know, is a challenge. So actually having clinicians that have got some interest in clinical informatics who can help with data extraction is a real help. And I sort of include myself in that group there. Being able to extract some of the data was far faster if you had a clinician who could engage with the data than if you were waiting on the hospital information services team. And observational design for COSMIC-19 was a big help as well. We said from the start that we wanted to get this technology into the hospital, but in doing so, we didn't want to integrate directly with the early warning score system. Had we done that, it would probably have set the trial back by months, if not years, because there would have been a whole series of governance that we had to go through to say how this was going to influence direct care. And we wanted to see what happened when we use these monitors. And so saying that it wasn't going to actually intervene on patient care was a real key part of that.
Okay, I think we need to stop there if that's okay, because
fine,
otherwise we would run over a little bit too much. So Anthony, thanks. Fantastic piece of work. I've got a few questions actually myself, which perhaps we should take offline at some point. I'd just like to open up the floor for questions to Anthony. So if you've got questions for Anthony, feel free to unmute or enter the question into the chat. Maybe I can kick off. So Anthony, are there plans to continue with this beyond the study? Because it sounds like something that is just really good idea and is, very useful to roll out on a routine basis.
Yeah, I think we've got a couple of options for continuing, Niels. So one option is the EMBRaCE project. So we're going to come on to hear in a little bit about how we're going to try and now do our CAR T-cell trial that we originally envisaged through the EMBRaCE project. The other one is that the company themselves, Isantis, are very keen to see how the technology can be evaluated more formally in a hospital setting. One of the challenges there is, I guess, designing the right kind of trial to do this. And to really understand, the health economic argument for using this technology and how it works when you upscale it on a large scale. So we're in sort of early stage talks with them to say, look, we've tried this in adults now, and really their work so far has been in children at the Birmingham Children's Hospital. But we're sort of saying to them, well, perhaps we could do some kind of, step wedge sort of trial where we randomize different wards of MFT to use this technology. And that would be a bigger piece of work and would probably need us to then really do some more integration with the hospital system. But the way to do it, if we had that sort of step wedge design, would perhaps be to dedicate our research nurses to training staff in how to use the equipment. It does still have its challenges. One of my comments there is about trends versus absolutes. We found that the temperature probe that you stuck under patients' arms gives you an absolute temperature which is significantly lower than what you get when you measure it tympanically or through another sort of traditional route. And that means, how do you integrate that information into an early warning score that you're going to act upon? And so there are technical issues, I think, about how we do integrate this and how it fits in with traditional vital signs. But yeah, certainly plans to look into that on a bigger scale if we can. And I've been speaking to colleagues at the university who might be able to help with that kind of design.
Okay, great. Thanks, Anthony. Comment and a question before we move on. So comment from Andy Bleeden, who's the chair of the ECH Alliance. Hi, Andy. Thanks for joining today. So Andy says he's happy to share the COSMIC-19 study via the wider ECH Alliance network to their newsletter. And then a question from Justine. So he writes, I'm interested in your thoughts about how this could be extended into the home, given your comments about how some of the tech is not suitable for the home environment.
Yeah, I think perhaps I'm being a little bit unfair to say that it's not suitable. I think it perhaps just needs a degree of training there. And I think, an interesting follow-on talk from this would be to hear from John Radford from the REACT trial. So John has used this same technology in the home environment. And I think we would potentially see a different set of challenges that he's faced there. I think ultimately the answer is training. And just like we needed to train up our research nurses, I think it's possible to train up patients to use this technology in the home. But it's a little bit more of a bulky system. And I think, the answer might be to extend this technology into the home is to work on making the profile and the form factor of all the kit a little bit smaller and more amenable to day-to-day life. And you're going to see from some of the stuff we're talking about in EMBRaCE that maybe there's a set of wearables that you can use in a hospital setting when a patient is being a patient, and then a set that you can use when they're at home, and they're kind of being just their normal self, that they're not in that patient role like they are in hospital. So I wonder if changing the form factor or using slightly different devices is the route that we should explore there, and have different wearables in each environment.
Yeah, no, I think that makes sense indeed. So thanks again, Anthony. Great piece of work and fantastic fit, I think, for the ecosystem. I saw that there are numerous questions in the chat. Would you be happy to answer them through the chat? And then we're going to move on and try to make up some of the time that we've lost. So without further ado, I'm going to introduce our next speaker, who's Zoe Merchant. So Zoe is a specialist occupational therapist at the Christie, and she's the qualitative research lead for EMBRaCE-GM. So Zoe, the floor is yours.
Brilliant. Thank you very much for having me, and following on from that brilliant talk from Anthony. So I'm going to start the talk about EMBRaCE-GM, very much going into the rationale for why we're doing this. And just to give a bit of background, so as Niels said, so I'm an occupational therapist. For the last few years, myself and John have been leading on the Prehab for Cancer programme, which has delivered prehab and rehab to cancer patients in Greater Manchester. Approximately 2,000 patients have been through that now. So a lot of the work we've done over the last few years has been really understanding cancer pathways and what goes on for a patient from the point of diagnosis through treatment and as they go into recovery. And we were lucky that as part of the funding that related to that project, we were able to purchase some commercial wearable devices, which Anthony's going to go on to explain what those are. But obviously what we want to do is really understand how we could use these devices and how we could apply research methodology to get the best out of supporting cancer patients using the devices, hence EMBRaCE. So I'll let Anthony go into some of the more the details about what EMBRaCE is about. And I'm going to just go into the rationale from speaking to patients, if that's okay. So we started off by doing a focus group in October last year. And I work for GM Cancer, which is the Cancer Alliance in Greater Manchester. I'm not sure if everyone's aware. So throughout the whole of the United Kingdom, all the different STPs have a Cancer Alliance. And the real aim is to bring together health systems and academic systems and patients and really try and drive cancer standards up as much as possible. So it's overseen by NHS England, and in Greater Manchester we've got the GM Cancer Alliance. So within GM Cancer we've got a really brilliant user involvement programme which consists of about 150 to 200 patients who've experienced cancer and family members as well. So we started by getting a group of those people together via a virtual focus group. And what we really wanted to do in this group is not go straight to the kind of solution, but really understand what the problems were. So we really talked through each of the patients' journeys and what they've been through having their cancer diagnosis, and for them, what was the main problems that they're just the highlights from that focus group that we did. And there was about 10 patients involved, and it was brilliant because there was some real variety in the people that were there. So we had some people who were very digitally savvy, and then some who probably would maybe even put them in that digital exclusion box. So the key things that they raised were, number one, the idea about who's monitoring me. So for the cancer pathway, often patients can be in and out of hospital, but they have huge chunks of time when they're at home, and they might not necessarily have contact from their healthcare professionals. So there's a great degree of anxiety about when they're going through treatment, for example, chemotherapy, actually who is actually monitoring what's happening for them on a day-to-day. You know, if for some people, they might not even have CNS, which is cancer nurse specialist involvement, after the first few weeks when they're first diagnosed. So that does really add to the anxiety that people experience when they're going through cancer pathways. The second element was around fatigue and sleep disturbance. So as many of you are aware, probably that cancer really does cause fatigue, not only for the treatment, but also for the way people experience the diagnosis and the psychological side. So fatigue is a real big issue, and this was something that was raised repeatedly through the focus group, but also then just sleep as well. And so this caused a lot of anxiety. So this came through as a really, really strong theme. The third theme was about physical activity and being able to continue doing everyday activities. So that ranged from whether that's exercise, gardening, you know, activities of daily living. So again, people wanting to understand what their levels of fitness were and have reassurance about the ability to do the physical activities that they were used to doing. Because again, going through cancer treatment, there's a lot of concern and worry about what they're doing and whether it's right to be doing physical activity. Number 4 was around the gap between hospital and GP. So I think it's remembering that a lot of cancer care is provided within secondary care provision in hospitals, and actually the GPs and primary care and community nurses and other healthcare professionals might not necessarily know much about what's going on for the patient when they're going through their cancer pathway, yet they are the first port of call if there's any issues for a patient whilst they're at home in their houses in the community. So yeah, that lack of communication between hospitals and healthcare staff was a real issue for many patients in the group. And then finally, really the psychological support and just understanding that, you know, as you can imagine, cancer is an incredibly stressful, anxiety-provoking and potentially mood-disturbing time. And really that what patients need more than anything is that increased psychological support. But it's obviously how do you actually access that psychological support when it's needed? So some of the themes that we pulled out from that focus group, they're echoed in the literature. So this is a brilliant study that was completed a few years ago. And what happened was they interviewed a range of healthcare professionals involved in abdominal surgery, cancer surgery, and then they interviewed a range of patients as well, to try and understand whether there was any correspondence between the kind of priorities as from the healthcare professional's perspective versus the priorities from the patient's perspective. And as you can imagine, the healthcare professional's perspective is very much around survival and around treatment and around the impacts of healthcare provision. Whereas for the patients, the really key items for them were, number one was around their energy levels, two, their sensation of pain, three, their general physical endurance. So going back to that idea about their fitness and physical activities. And then number four, just being able to carry out normal daily routine and activities. So it's just showing that actually the literature really does echo what we found from speaking with patients. So just going back to fatigue. So as many people might be aware, cancer-related fatigue is probably one of the most common symptoms that anyone going through any type of cancer, whether it's a different tumour or different type of treatment, surgery, chemotherapy or radiotherapy, fatigue is really incredibly prominent, and it's incredibly debilitating. So for example, if you're trying to continue for your normal activities of daily living, if you're trying to work, if you're trying to look after children, it's that literally that ability to, no matter how much sleep you get, you literally don't have any energy or ability to engage and be motivated to do your normal activities. And so it's seen in up to 90% of patients who have radiotherapy and chemotherapy. Fatigue is incredibly subjective, and we know with cancer-related fatigue that it's not just a physical situation, it's actually often a very psychological one, often probably connected to people's ability to cope with a cancer diagnosis and the fear that comes with that. And worryingly, it can persist for long time scales. So there's evidence that people who are 10 years out of having had their radiotherapy can still be experiencing fatigue, which is obviously incredibly impactful in terms of their ability to carry out their daily life. So this is something that's still poorly understood and needs a lot more research, and an idea that we really are focused on within the hypothesis between the EMBRaCE project. So thinking more from other reasons for why we're doing EMBRaCE. So within the NHS long-term plan, there's a whole chapter dedicated to digitally enabled care and how we can really move the NHS along in terms of using digital technology to improve healthcare provision. There's also a huge focus on personalised care delivery. So that's how you really make sure that healthcare is provided holistically for individual patients based on their own needs. And a big part of this is self-management. So it's understanding that many people are surviving longer, certainly in cancer. And also we've got an aging population of people who are, going through complex different conditions and coming out the other end. And it's how they survive, what they survive with, and understanding that you can't rely solely on health and social care provision to make sure that people have good quality of life during disease. So it's really about how you support people to self-manage health conditions and self-manage their ability to carry on doing their daily living despite having disability or illness. The other idea within the personalised care model is that not everyone needs the same provision. So on the left-hand side, you'll see what's called the universal targeted model. So this just breaks people up into different elements in terms of what they actually need in terms of their healthcare provision. And there's an understanding that the whole population, you can do what's called a universal offer, which could potentially be quite light touch, but where digital could really come in to support people. And then as you go up the triangle, it's understanding that people's needs become more complex depending on the different conditions that they have. And you go from needing that universal offer through to very specialist hands-on provision from expertise within the healthcare professionals. So some of these ideas we've really brought into the EMBRaCE project in terms of how you could bring wearables to support people in their personalised care and into healthcare provision. We are anecdotally know lots of information about the way cancer clinic appointments are done at the moment. So there's a push again from the NHS England to try and reduce the number of face-to-face appointments by a third. And this has been accelerated by the COVID pandemic. So actually, I think they're looking at more like 50 to 60% of clinic appointments now wanting them to be video or telephone calls rather than being in person, face-to-face. But with that, there comes a whole load of risks associated with cancer provision. So for example, we know that a big part of monitoring someone as they're going through cancer treatment is keeping an eye on their weight and their BMI. And if you're not actually seeing someone in a clinic environment, how do you get that information accurately? Because often patients don't have weighing scales, and their weighing scales might be completely out compared to what you would have in hospital environment. And there's lots of other aspects like that that you're going to miss from potentially not seeing somebody in person in a clinic as opposed to seeing them via video or telephone call. So these are real issues within the NHS at the moment that need to be addressed. We also know that PROMs are being used more widely, and certainly at the Christie, there's a big e-PROMs initiative that's happening. But the problem sometimes with PROMs is when people are reporting their quality of life using validated measures, often not intentionally, they might actually skew some of the results, because patients at this point are very concerned with their survival, understandably. So if they're being asked about nausea, fatigue, other elements, pain, there is always that risk that they're actually going to potentially misreport what's they're experiencing, because there's that fear that if they report the accurate symptoms, that actually that might impact on the treatment that they're being offered. And I've had the privilege of actually being able to sit in on some of the lung cancer clinics that go on. And this is something that the nurses and the doctors are really aware of. They look at the EPROMs and then they have a conversation with the patient, and often the two don't marry up. But that information is really important when you're trying to prescribe chemotherapy and trying to minimize the risk of toxicities and side effects that can actually be life-threatening if people are having the wrong kind of treatment despite going on to have side effects. So this is a really important bit, and it's about that piece, that gap in the puzzle that we really need to try and fill. And then finally, it's just knowing that whilst patients do have regular clinic appointments, they really don't feel that's enough, and they really would like to have more monitoring and more support. So what's the best way of doing that in an efficient, with using health economics in terms of how you understand how that can be provided? So finally, I'm going to let Anthony go on and talk about all the devices that we're going to be using in our research study. But when we did the PPI group, we did talk through some of the wearable devices that we were going to be using, and patients responded really well to this. They were happy to be wearing several devices at once. They could absolutely see the benefits of the data that you were going to get from the devices, how the healthcare professionals could use that information, but how they as patients on a day-to-day could use the information that they would see within their apps for the devices as well. And so we got the feeling from the PPI group that this was an absolutely an acceptable research study to go ahead with. There were some challenges raised about people who might not feel that they wanted to engage with their apps on their phones at certain points in the pathway. So that's something that we need to take into account. And also it's just being mindful that not everyone felt as digitally savvy as others. So it's taking that into account as well. And just finally, we've got Steve Sweeney, who's our PPI chair, and this is a patient who's actually experienced radiotherapy himself. So he's a big member of our team, joins all our meetings, gives us really good advice from a patient's perspective, and he actually oversees our PPI group, who are going to be meeting bi-monthly throughout the whole of the project to be able to give us feedback as we're going along through the study. So I'll hand over to Anthony now, who's going to tell you more about the project.
Thanks, Zoe. So yeah, I mean, hopefully now you've had quite a comprehensive introduction to what we think is the rationale for this EMBRaCE project, which stands for Enhanced Monitoring for Better Recovery and Cancer Experience in Greater Manchester. And we can probably go on to the next slide there now Zoe. So yeah, with the things that Zoe's said, what we want to do with EMBRaCE really is to ask a series of questions. We want to know if wearable Vital Signs monitors can provide useful data during cancer treatment. We want to understand if such devices are acceptable to patients. And we want to get some idea of what we can achieve with the data that we can obtain from these devices. And finally, as sort of something that's come up in the chat already, is we want to understand what healthcare professionals think of this data and how they might be able to use it in the course of caring for patients. And the challenge that we're trying to address with the EMBRaCE platform, which is what we're going to call it really, is the fact that there's different groups of patients having different treatments and the potential to monitor them with a whole host of different devices. So you could, rightly ask, well, are the answers to these questions the same for these different groups and using these different devices? So we can move on to the next slide again, please. And just to illustrate the point, there are a whole host of different vital signs monitors, health and fitness trackers, whatever you want to call them. At one end of the scale, there are commercially available fitness monitors or well-being trackers, and the examples that I've got there are the Oura Ring and the Withings Scan Watch, which we're going to use in the EMBRaCE project. And then at the other end, you've got things like the iSansys devices, which are CE-marked medical devices with a specific indication for use in hospital. So there's a scale of things in between there, and devices that work in a variety of different ways. So how do we appraise all of them? We can move on to the next slide. And when we appraise all these, there's lots of avenues that we could explore with how potentially we can use the data that's obtainable from these devices. And I've picked 4 papers here, but I could have chosen from a whole array of different ones in different tumor types, in different patient groups. There's the impact of exercise and how we track exercise at a sort of simple scale. There's the fact that many of these devices record heart rate variability, which has sort of been associated with stress, with recovery from cancer, with outcomes, and with ability to tolerate chemotherapy and radiotherapy. Many of these devices record sleep, and sleep's often an unmeasured variable that isn't incorporated into lots of cancer studies. So, have we got an opportunity to incorporate measures of sleep into cancer studies through these devices? And then with certain tumor groups and certain treatment types, and the example I've got in the bottom right-hand corner here is CAR T-cell therapy, there are specific toxicities and specific complications that patients face, some of which can be life-threatening. With this data, are we in a better position to predict in advance when these toxicities are going to happen and potentially do things to mitigate them for patients? So we've got lots of devices, lots of different groups of patients, and lots of avenues that we could explore with this data. And that's why I think we need something like the EMBRaCE platform in Greater Manchester. So Zoe, if we can move on to the next slide. Essentially what we're talking about here is one trial that can have a multi-cohort design. And this is a kind of a basic sketch out of what we're thinking with the EMBRaCE project. So we've got 2 sites in mind. And at the moment, as we're setting it up for the first stage, we've got 3 different cohorts of patients that we're going to investigate. So you can see at Manchester, at MFT and at the Christie, we've got a group of colorectal cancer patients, a group of lung cancer patients, and a group of patients that are having CAR T-cell therapy who have lymphoma. And each site can collect data and work in this same platform under the same ethical approval of the EMBRaCE project, because we're designing them all with the same aims in mind. And we think this is scalable and adaptable and flexible, and that's what we're trying to promote. So if we can go on to the next slide, and then if we can just maybe click on a couple of, that's great, thanks. Yeah, so as well as having a sort of trial governance structure, which you've just seen there, that enables us to adapt this and use it for different patients and different tumor groups, we wanted to create a platform that could allow us to capture data for all of these different groups of patients and treatments in one place. So with an AI partner in Alderley Edge, Zenzium AI, we've set up basically a data set, a data tool that allows us to capture data from a variety of different wearable devices, and also to include surveys and patient-reported outcome measures from patients via their mobile phones. Now, collecting that data in and of itself is good, but it really needs to be combined with the electronic health record and the information about the treatment that the patient's having in hospital, some of the routinely collected healthcare data. So we're proposing, and what we're setting up is the EMBRaCE electronic data capture tool. And this would be a database that we're building with our contract research organization, Aptus Clinical, so that we can capture that data and then feed that into our data set for wearable innovation. And the idea is that when we've got all that data in one place, it'll be a compelling source that we can use to answer some of these questions, or at least generate hypotheses for further interventional trials and research in the first instance. So if we can click on one more time. Yeah, and the key thing about it, as I'm going to say in the next slide, is that we're aiming for an adaptive design, and in which we have one tool that works for many cohorts of patients under the same governance structure. So if we can move on to the next slide as well. So in terms of our data model, what are the key features that we're trying to build in? Well, we want a modular design. We know that most patients are going to have some kind of cancer treatment. So there's going to be a module to capture data on their surgery or their chemotherapy or their radiotherapy. We know that most patients are going to have blood test results captured, so there'll be a module for that. But what we want to be able to do is to bolt on an additional module if there's something specific for CAR T therapy. Rather than having to redesign the entire database, we bring that in as an extra module, and that should help it to be scalable. We want the system to be device agnostic, so that in cohort 1, we can look at Oura rings and Withings scan watches, but it doesn't matter in cohort 15 if we decide to look at an Apple Watch. And this, we hope, will mean that if we want to add a new study cohort, it should be simple and it should be relatively cheap, because we're not having to build a new ECRF for 30 or 40,000 pounds every time. We also want to make sure that the database is optimized for time series analysis. One of the learnings that we've had from COSMIC-19 is that really when a company that's used to doing clinical research trials sets up a database, they set it up with a drugs company and FDA approval and CDISC formatting in mind. And all of that is great if you want to do that. But if you want to do something that's moving a little bit more dynamically and adding data on a minute by minute or hour by hour setup, then you need to design it with that focus in mind. So one of the things that we've been building is an API to extract that data on a regular basis in a sort of a format that permits a sort of time series analysis for our AI providers. We also want to have a standardized data model, and something like OMAP. OMAP would be the ideal. Whether we're going to get there or not, I don't know, but that's what we're aiming for. And lastly, we want data sharing and collaboration agreements, which we've already set up through COSMIC-19, to be already in place, so that if people want to come and add a new cohort to EMBRaCE, it shouldn't be a real hurdle to get over some of the sort of governance and bureaucracy that goes with that. So if we could just move on to the next slide, Zoe. So this is just an example really to illustrate how this is going to work. So cohort 1 is a group of colorectal patients. We're going to monitor them for up to 26 weeks with a Withings scan watch and an Oura ring. And if we can move on again, Zoe. For them, there's going to be 20 patients. We're going to look at them throughout their treatment journey, and there's going to be an option for them to be monitored for that the entire time with those 2 devices, to have weekly patient-reported outcome and device satisfaction surveys using the FACT-C patient-reported outcome tool, and an option also for them to report ad hoc symptoms as well. So this is probably one of our more simple cohorts. And then at the other end of the scale is the CAR-T cohorts. So if we move on to the next one, this is cohort number 3. With these guys, we're going to do the same things in the community when they're out and about with a Withings scan watch and an Oura ring. But when they're in hospital, we're going to monitor them with a scale so that they can take daily weights. And we're going to also use a slimmed down version of the iSantis monitoring platform. You heard me talk about some of the difficulties with blood pressure cuffs. What we wanted to do was to take that bit out and allow that blood pressure measurement to be made by a nurse, because we think that that works better, and it also maintains that face-to-face interaction with the patient. But that'll allow us to assess this whole range of suite of devices in those patients. And you can see in the next slide that the timeline for those patients is a little bit more complicated, but it's all achievable, we think, through the same sort of governance structure and data model that we're building with EMBRaCE. And quite possible to put more in. I think, Niels, that's me finished.
Okay, great. I was just going to jump in and say we've got about 9 minutes left. I think at some point you'd like to hand over to John probably, but you're finished, right?
Yeah. Zoe, I think you had a little bit of work on human factors research, didn't you? So that would be the only other thing to add in, and then, yeah.
Okay, I'll just whiz through this quickly.
So we've got about 9 minutes left, so that's just that you're aware, right?
Yeah, that's fine, that's fine. Okay, so it's just to basically say that in addition to everything that Anthony's described, we're aware that we really need to include much more rich qualitative information. So this is just a little bit of a background about myself as an occupational therapist. So I'm going to be doing semi-structured interviews with patients, using a lot of my knowledge clinically from working with people in their own homes, because I've done a lot of community work where you really do understand all the different aspects that might impact on somebody's ability to engage with something. So understanding that we really need to know what the problems might be about them wearing the wearable devices, and how they can get the most out of using the app and using the wearable devices. So we're going to be doing semi-structured interviews with sample from within the different cohorts that Anthony's described, approximately 20 to 30 patients. And we're going to be picking a mixture of different people, understanding that they'll have gone through different pathways related to the cancer, that which we're really experts in already. Most likely by the telephone, because we know that that's something that's accessible to people to do semi-structured interviews that way. And some of the questions that we really want to get into is wondering about the devices that people are wearing. So we're using a ring versus a watch. For example, issues may come up, like, for example, people often have edema when they've got cancer treatment. So can they actually wear a ring? Because straight away that's going to be an impact if they can't. looking at different points in the pathway. So whether people are going to be likely to wear devices for maybe before their treatment, but maybe it'll drop off after their treatment, and how long for the trajectory after treatment would they be prepared to wear the devices and link with the apps. So that's a really key aspect. We really want to understand from the patients benefits that they identify. So using that qualitative approach to really get that rich data from them about potential ways that they can see that this would really benefit them as a cancer patient going through their recovery. And then finally, there's lots of questions we need to know about leveling up. So understanding whole ranges of patients who might not necessarily be able to access some of the information and what support they need from the research nurses. So that's going to be a really key part of this qualitative research. The other aspect is healthcare professionals. So obviously, with patients wearing these devices, we're expecting that they're going to be speaking to their doctors and their nurses about the information that comes up on their apps. And so we're going to be doing some focus groups with the different cohorts that Anthony's mentioned. And it's going to be a mixture of getting feedback from them about how they found interacting with patients who've been using the wearables. But then also what we're going to do is we're going to take some of the simple AI modeling from the data we've collected from the devices and present that to healthcare professionals and really get their feedback on how they think they could interact with that data as part of their healthcare provision and decision making within a cancer pathway. So really getting the healthcare professionals' view. And then finally, it goes back to everything that Anthony's mentioned previously, which is understanding all the logistical considerations of how you can link device information and wearables into the existing ports of information that people already have within hospitals. So electronic healthcare records, but also PROMS data and information that they already get. So that's just going over to John now. These are just some of the qualitative aims that I was hoping for some of the research that I'm going to be doing. So I'll hand over to John now.
Thanks, Abe. So just to finish on, I think it's just so colleagues are know and aware that we're considering how we fit into what's already happening in Manchester. And as Anthony explained, lots of work going on with John and Niels' work with the ADAPT and also with REACT, looking at both ends of the patient's pathway. So this is just an overview, I think, where some of the digital cancer research exists in Manchester at the moment. So we're looking in the middle area, which is the commercial grade wearables, where we're looking at physiological and psychological monitoring. And to the left, you've got the acute deterioration, which is COSMIC REACT. And then further down the line is the ADAPT work that John and Niels are working on. Next slide, so if that's okay. I think it's good, though, to consider what's happening outside of Manchester, and it's very good to see all the colleagues on the call. There's lots of work from a surgical prehab point of view about what's happening across the north of England, Sheffield, Leeds, Liverpool, South Tees, and also with colleagues in Scotland. And I think it's worth people knowing that all these areas are developing their own solutions. And I think it would be helpful with Niels and John considering this as well about our ecosystem and how we reach out to those colleagues, because I think there's a big opportunity in Manchester for us to lead a lot of this work. And but as I say, there's, for instance, colleagues in Sheffield, Prof. Jim Cato, who's a NIHR prof in urology, is doing some very interesting work in just using step counters in his prostate patients to understand their recovery. And very simply, if your step count is low after surgery, your recovery is not as good, and they then intervene based purely on the step count. And they're also looking at technology where anyone coming into the hospital, whatever their wearable device, they can then engage that or app or phone, they can then engage that with their health record. So what I think would be a good next step for us in terms of the Northern collaboration is to probably meet with some of those colleagues alongside some of the colleagues on the call, so we can understand what we're all doing and where Manchester might add value and lead in some of these areas. To the right-hand side is more the local EMBRaCE work, where we take the work that Anthony's leading on in terms of the observational work, and then hopefully work to a local intervention trial with new technologies and linking into colleagues in the biological timing group, the engineering group, and HERT within the university. But I do think, really to frame it, there's a massive opportunity for Manchester to lead on a lot of this work across the north of England. And as I say, we've got some very good relationships with colleagues already existing with all the work we've been doing so far. So really some of this is a pitch into yourselves to think how we might take those next steps forward. So probably that's how I would summarize where I think things are up to, Niels, if that's okay.
Thanks very much, John, Zoe, and Anthony. That's, I think, a great vision actually for the future in this space. And I must say, I'm impressed by the work that you've done and what the potential that is offered by the EMBRaCE platform. So I think surely this warrants further conversations that I'd be very, very happy to have. Let me check what's going on in the chat. I've seen that lots and lots of people are entering questions into the chat. So maybe we can pick up a couple of those over the next 10 minutes before we move on. So maybe before we do that, actually, I had a question myself, which might be for yourself, John, or for Anthony, I don't know. But so I was at a workshop yesterday organized by HDI UK and British Heart Foundation about the use of consumer wearables in cardiovascular research. So both HDI UK and the Heart Foundation, I think, are very keen to move that field forward. One of the things that came up in the workshop is that there is a bit of a tension between what companies who operate in this space want and typically how their business model operates and what we as researchers want. So we typically want things like transparency, replicability, all those things that are important for science, whereas for a commercial entity, those things actually are quite threatening. So typically, companies say, we've got our own proprietary algorithms on the wearable that will process any raw data before it is made available to anyone else. And we can't tell you what that is. And that is even true for simple things like step counts and activity measurement, etc. So what are your thoughts on that? How do we resolve that tension in this space?
John, if you don't mind, I'm happy to sort of contribute on that a little bit, because I know this has come up when we presented EMBRaCE previously, Niels, and it really comes down to that sort of validation question, doesn't it? How do we validate, the truth of the information that we're getting? And a question that I've just been, I think Rachel pointed out in the chat, which is a great thought, is, how do you compare these commercially available devices with, CE marked medical devices, and be confident that you're reliable. And so one of the things that I've come across recently is that the FDA have sort of changed their stance a little bit on this, and then they're now talking much more about real world evidence. And our AI partner from Zenzium AI, Tony Bashel, would say this if he was here, that actually that they seem to be more interested in trends from these devices and capturing that information and using that to sort of make predictions. And I would question that if we don't know the algorithm, if we learn and we use the data that's available that comes out of the algorithm, does that matter? If we can still demonstrate that outcomes for patients, do we need to be just a little bit more flexible with the truth, for want of a better phrase? And maybe that's what the FDA are driving at. And I don't know. I can see that has criticisms from a sort of a scientific and a technical point of view. But I think patients, if you ask them, we don't know what the algorithm does exactly, but we know, or we don't know what the proprietary model is for how this data does. But if we get the data that comes out of it, we can learn from that and we can make the outcomes better from you. I think that they actually, that's what they want. So I can see why the FDA might be moving on that approach. I don't think that answers the question fully, but John, I don't know if you have anything else that you would add at that point.
I suppose, I think it's a really good explanation from, we had conversations, Niels, if you remember, with Google, with Apple, when we started this process. We didn't really get anywhere. There's no traction because it didn't interact with what they wanted. They've got their own vision of healthcare, haven't they? But when we sat down with Zenzium, it was a much more open conversation, I think. So I think having an industrial partner embedded in your team, if you can allow that, and I think that's where the universities, where the UOM, where we need to get to as MFT, and just say, well, that's normal for us now. We have an industrial partner who allows us to see our data, but also allows us to visualize these other things about where industry is getting to. So I think also from a patient perspective, they want it to be very straightforward, don't they? They want a seamless journey from ideally one app or two that interacts with their healthcare record. And I think that's our next big challenge, Neil. How do we take this wearable information into Epic, into the solutions in GM. That's, I think, once we get to that, the next 2-3 years would be amazing, actually. Yeah,
I completely agree, and I share your experience that, you know, working with the big tech companies, obviously if you can make that happen, there's a huge reward, but it's very, very challenging. They have their own agenda, as you say, and my experience is also that can change at any point in time, at which point the collaboration tends to end. So not easy. Perhaps I could ask Andy. So Andy, I saw that you entered into the chat that it would be great to disseminate this information also to the other ecosystems and perhaps work with them. So maybe you want to unmute for a second and tell us more about, you know, what you see as the opportunities in that space.
Well, thanks for that, Niels. Just as someone who's been involved with the Manchester ecosystem since it kicked off, I'm passionate about seeing great progress from Manchester. I'm alarmed to think that we only could validate this perhaps in the north of England. We've got 65 other ecosystems, just like the one in Manchester. Globally, it would be passionate about collaborating with you, learning from your experience. We can help do that as part of the European Connected Health Alliance. This ecosystem in Manchester is part of a wider network, and there's an obvious key interest in each one of those ecosystems on cancer and cancer treatment and research and care. So that needs to be amplified outside, dare I say it, the walls of Greater Manchester, and maybe even it would be even riskier and outside the walls of England and the UK. We're part of something bigger on this, and the more we share, the more we collaborate globally, the more likely you're going to get more validation of what you're researching. We've, you know, certainly as an organisation, we've got membership from about 230 different universities who would be very, very keen and probably also replicated this work themselves. So we need to start connecting some dots between our ecosystem and the rest of the global network we've got.
Thanks, Andy. Yes, I completely agree. And the ECH Alliance, I think, is a great way to kickstart that kind of collaboration. So let me act as a conduit between the Alliance and the EMBRaCE team, and start spreading the word to that large international network.
Yeah, we can feature that in our newsletter. It'd be a great interest.
Great. I'm going to move us on in the interest of time, but please continue the discussion that is already ongoing in the chat. Thanks again so much to John, Anthony, and Zoe. Great presentations and fantastic fit, I think, for the ecosystem. And we'll hope to invite you again in perhaps a couple of years' time to see more results. And offline, I'm very keen to have a conversation with you guys on EMBRaCE-GM as a platform for the entire region, and how we can perhaps embed that into the Pankhurst Institute. So our next speakers are Ettah, and Seonaid Lafferty from the FEMH Business Engagement Team and Digital Futures from the university. And they're going to tell us about the two foundries that we have, the AI Foundry and the Cyber Foundry. So Effa and Seonaid, the floor is yours.
Hi, good morning, everyone. Thank you for having me today. I'm just going to share my screen. Can you see that okay?
Yes, we can.
That's great. So just to introduce myself, I'm Seonaid Lafferty. I'm the project manager of the Greater Manchester Cyber Foundry at the University of Manchester. I just wanted to take this opportunity to tell you a little bit about the projects, two projects that we have within Digital Futures. So the Cyber Foundry and the AI Foundry are ERDF funded projects, working with SMEs within the Greater Manchester area to support business growth, identify opportunities, with a focus on innovation within technology. So this feeds really nicely into some of the conversations we've heard today around collaboration and engaging with technologies, and really about reimagining the future. So the projects are split into 2 phases. Phase 1 is a series of interactive workshops, which give SMEs skills and knowledge in the project area, and they focus on innovation, capacity, and strategy. So they really help businesses to identify some of the driving forces that may create challenges or opportunities for their business, and invite them to take a step back and explore collaboratively. Phase 2 of the projects, that's really the technical intervention stage. So SMEs work with a research institution with expertise and to bring new services or products to organisations or markets. In CyberFoundry's case, this is about embedding cybersecurity into products or services. So this could be anything from bringing a proof of concept to market, to finding new ways to generate or sustain partnerships in custom, or to help systems and processes in their efficiency within their staff team. In the CyberFoundry's case, this is about supporting and strengthening defence through innovation. So in 2019, 32% of businesses experienced a cyber breach, most of which were undetected. And these are becoming increasingly sophisticated, and the impacts are extensive, but most importantly, they stifle businesses' confidence to grow digitally. But CyberFoundry isn't just about defence, it's about giving your business the confidence to adapt and evolve in a changing landscape. So businesses can embrace new approaches because they feel more confident to use technology, data, and they process information much quicker. The AI Foundry supports businesses to explore options and enhance their value proposition. Currently, only 10% of UK businesses use AI, and those that do, wherever there's been growth, it can be directly attributed to the use of AI. So the Foundries, finally, are at no cost to your business whatsoever. We just ask for your commitment to engage with the project and complete some pretty extensive but necessary paperwork, unfortunately. If you or anyone in your network might benefit from working with either myself at the CyberFoundry or Effa at AI, please do get in touch. Thank you.
Thanks, Shona. Could I ask, maybe it's too early in the process, but do you have any examples of businesses that have engaged and, for instance, what they then got out of it, or how they progressed or innovated through the process?
Yeah, well, I can speak for CyberFoundry. So CyberFoundry's in its last year, whereas AI Foundry is just starting up at the moment. So I can speak a little bit about CyberFoundry. Firstly, it isn't sector specific. So we have a really wide range of businesses engaging with the project. And most of the time it is bringing proof of concept to market. But we have worked with, as I said, kind of mentioned, enhancing operations within teams as well. So just, like I said, just kind of giving confidence to organizations, because once you feel safe in that area, you really have capacity to think about the future and what the possibilities are. So in phase 1, it's currently run online, understandably. 2 half-day workshops and 1 full-day workshop, during which you're kind of given the government rubber stamp for cyber essentials, as well as business modelling and looking at your innovation capacity. But in phase 2, that's when you work with research institutions. So you have access to up to 45 hours of expertise. So it's a really fantastic project. I know I'm the project manager, but it's a great opportunity. And like I say, it's at no cost to the business at all.
Thanks, Shona. I see in the chat that Patrick, who's actually a fellow Dutchman, has engaged with the CyberFoundry. So Patrick, would you like to unmute and perhaps tell us a little bit about your experiences?
Yes, indeed. I mean, the AI Foundry is very similar to Cyber Foundry, except that in this case, we are not just trying to protect the SMEs in cyberspace. We're trying to create opportunities to use artificial intelligence to enhance their business models and analyze the right kind of data, and of course, build the kind of innovation that will improve returns on their investment. For instance, in the last 3 months, we've engaged with an energy company that is building solar-powered systems for homes and businesses, and we're helping them to generate the right data in order to know where they should drive their market or drive their investment. That's on the business side of things, but of course, we are interested in people across various sectors, whether it be medical or manufacturing or even education.
Right. Thanks, Effa, for stepping in. So I mentioned Patrick.
Yes.
Would you like to share your experiences with the Cyber Foundry with us?
Yeah, sure. Yeah, so I actually enrolled a few weeks ago. I have to say initially I wasn't sure whether this was for me, but it's a fully funded program, really easy, to enroll, and I'm trying to set up, an innovation center in Manchester, and this actually slotted in really, really nicely. So what I really liked, there was a lot of time to listen, to the initiative and see how, and just to see how the Cyber Foundry could actually match with this. So not only am I going to gain the relevant skill sets, and experience over the next weeks, but we're also scoping kind of project together and seeing how we can leverage the Cyber Foundry, and how we can leverage that with the innovation center. So I think it's a very flexible setup. It's as I said, really easy to get into, and it's a very pragmatically run. So yeah, I'm obviously I still have to go through the actual program, but so far I think it's really positive.
Thanks, Patrick. That does sound really positive indeed. So thanks for sharing that. So Seonaid and Effa, we're obviously going to disseminate your slides as well as the recording to the entire ecosystem community. So apart from the people who are on the call today, it is going to reach that entire community, and hopefully that can bring more businesses into that process. So thanks. And I'm going to move on to the final topic on our agenda, which is a presentation on the ERDF R&I Accelerator by Ania from the Strategic Funding Team in the Faculty of Biology, Medicine and Health. Ania, are you alone or together with Radina?
Alone, I think, the presentation, but I guess with Radina, if she's on the call, we can take questions together if there is any questions. Okay.
The floor is yours.
Okay, so I'm going to be very brief because I think this project, this ERDF project, has been presented before on that forum, but I will present the slide again and again show how complementary we are with Effa and the Greater Manchester Artificial Intelligence Foundry. So let me share my slide, and the question would be like usual, can you see my slide? Yeah, is it okay?
Yep.
Okay, cool. We've been awarded last year on the 1st of October the ERDF project, which is a Greater Manchester Research and Innovation Health Accelerator, and it's a part of the ERDF Priority Axis 1. So similar to, oops, can I move? Yeah, similar to Effa's project. So this axis is focusing on helping SMEs to commercialize their research and to have access to academic expertise with research institution and the higher education sector. So because it's been funded in Greater Manchester, we have to work with local SMEs, but we have put in place a virtual tenancy program, so we can, case by case, see how SMEs outside Greater Manchester can still participate to the program by having a virtual tenancy with Manchester Science Park. So we work with local SMEs, and is to accelerate the development of product, of process, or product to market or process to companies, and this is by collaborative research project with academics at the University of Manchester. So the project is led by Health Innovation Manchester, but there are a few partners. So there is the Manchester City Council that support the project. BioNow is involved, and the Innovation Factory, which is the technology transfer office of the University of Manchester. So we engage with companies at a broad range of TRL level, and this is because we work with Health Innovation Manchester. So Health Innovation Manchester work with companies in higher TRL level. So when a product has been fully demonstrated at scale and that it needs a little push to be commercialized or deployed into the NHS in Greater Manchester. So typically what I would say is that if SME enters that project, if it's in high TRL level, or if they have already an advanced product but issues with deployment with the NHS, not issues but barrier and challenge towards that effect, as they will be working with Health Innovation Manchester, will provide specific bespoke support to develop this product. For lower TRL levels, so where the product is still in development but there is some challenge, barrier associated with further development of this project, then the University of Manchester can help support the development of a project by giving expertise, academic expertise related that is relevant to the project, or health economic support, or value proposition development support. So typically, I would say from TRL 3 to 5, the University of Manchester would be the main contributor of support, and from the higher TRL, probably Health Innovation Manchester. So this is detail about the size of the project. It's a 4 million project, and the contribution from the University of Manchester is about 2 million to help. So here it's a summary of the SME journey. So it describes the support we are providing through the project. So of course, because it's an ERDF project, which involves a lot of rules and regulation, we check when a company comes or enters or registers their interest to participate to the project, there is a compliance and eligibility rules. But then there is a level 1 support, level of support, and this includes all this package of intervention that range from ethics and regulatory advice to translate or commercialize health technologies, how to navigate the health and care system, some support for health economics analysis, support developing value proposition, and this will involve all the partners. So this support can come either from the University of Manchester Innovation Factory, but the relevant expertise is available. Then when we establish a project plan and we have a clear idea of what is required to develop further the project, there is what we call a level 2 support, which involve funding and programming projects. So there is again supporting real world evaluation depending on the needs of the project, and on the SMEs there is again a different package of intervention. There is also financial support that comes either from Health Innovation Manchester and the University of Manchester, but particularly for the University of Manchester, we have pump priming project in collaborative with SMEs, working with academics at the University of Manchester at a level of up to 20,000. And this will include resources in a form of a technical assistance with a postdoctoral fellow or research assistant. It depends on the need of the project, but we have funding to collaborate on those projects. So I think I'm going to stop here. There is a lot of information on the website via the Pankhurst website. So I invite you to go on the Pankhurst Institute website at the University of Manchester, where there is information about this project. You can either contact me or Radina, who is on a call. And also there is more info. There is also information in the Health Innovation Manchester website. I'm happy to take a question if you require more information, or you can contact me directly offline. Thank you very much.
Thanks, Ania. If you could release the screen. Are there any questions at this point for Ania?
I have one. It's probably a bit boring, I'm sorry. But I'm just thinking about how the ERDF RNI and the Cyber Foundry and the AI Foundry are related. I've got something in my head, but I think it's wrong.
So the RNI accelerator is looking at health technologies. So it will include digital health technologies, but it will also include medical devices. It can range with diagnostics, imaging technology, medical imaging, and so on. So it's broad in terms of health technology. It could be as well a drug delivery system. So yeah. So that's the remit of the RNI accelerator. So it includes digital health technology, can include artificial intelligence applied for healthcare, but it's not, it's complementary in a way that we look at all other medical devices and medical engineering technology.
Okay, and so they're complementary parallel projects, the three of them?
Yes, yes, yeah.
Yeah, so the Cyber Foundry and AI Foundry, the focus is on really enhancing the SME community within Greater Manchester. So it's more focused on innovation and growth of SMEs, in particular through technology.
Okay, guys, I'm going to move us on because we're running out of time. But I think actually it might be a good idea if we sit down at some point and perhaps, create a little bit of guidance, because I understand Ruth's question, right? So if you're a company, when should you engage with which program, right? There's now quite a lot to choose from. So maybe we should help people to navigate this space a little bit. I mean, we understand it ourselves, but we need to help others to understand it. But let's do that offline. So many thanks for that, Ania. As with the two foundries, we'll obviously disseminate all the information to the entire ecosystem community. And that brings us to the end of today's ecosystem meeting. Many thanks everyone for joining, and many thanks to all our speakers today. I thought it was a very good edition again. The next ecosystem is going to be held early July. We haven't got a date for that yet, but we will let you know as soon as we have it. It's going to focus on regulation and regulatory processes for health technologies. So think of things like MHRA registration, CE marking, all those things that are terribly complicated if you've never done them. Luckily, we've got some people who have experience in that space, and they're going to share with you what they have learned from those experiences. There's also going to be a second ecosystem again in July, but then late July, the 26th, if I'm correct. But we haven't got a topic for that one. Again, as soon as we know, we will obviously let you know. And with that, I'm going to wish you a very pleasant rest of your day. Thanks again for joining, and I hope to see you at the next meeting.